Hello and welcome to Village in Motion. I'm Marcia Boyles and I'm delighted to begin this segment of our program with Christine VandenDries, who is an administrator. Are you the associate administrator?
I'm the administrator.
You are the administrator.
The administrator.
Oh my goodness, Christine, I almost, gave you an inferior title.
Oh no.
Christine VandenDries is the administrator of home health.
Home care.
Home care, is that the way you're putting it? It's home health and home support?
It is. So I'm the home care administrator. So
you are the
home care administrator, and now I have an assistant administrator.
Oh, you
which
do?
is wonderful. Yes,
Lois.
Lois
Yes.
Calloway. She came on board with us about a month ago. So
yes.
She helps me more on the home support side of things right now. Eventually, over time, once she's got the home support gig down,
right,
we'll have her learn home health. But home health is so heavily regulated by the government, and usually most of the time administrated by like an RN because of the regulations and things
right,
that we know.
Because that's Medicare reimbursable.
Right.
Yes.
So it just takes more time to learn that if you haven't been in the
can
practice.
imagine.
So she's focused on home support right now, learning the ropes and getting out in the community, helping us market, and then helping me just kind of figure out the direction of where we want to go in 2020 with the whole home care team.
Ah, well, of course, Lois has been here so many years, and many people know her, of course, as the head of pastoral ministries. So we were all very surprised, and I ran into her a couple of days ago, and she seemed to be delighted at her new position.
We love having her down there. And for me, it's a treat to walk around with her because so much of what I do is business and financial in the office, handling things. So people don't know me that well, even though I've been here going on 2 years now.
Has it been that long?
It has. It'll be 2 years in May. And walking around with her, everyone knows her. So she keeps introducing me as her boss. I'm like, she's my teammate, it's fine. So, I'm the administrator, but we are one team down in home health and home support. And so, being a nurse and, I've gone out and done visits for clients and, we all kind of take on each other's roles, especially with, the nature of this time of year and illness and vacation. We're all doing each other's jobs at any time. So. All
right. Well, that works well. Yeah. Yes, it would be nice to have somebody that knows everybody in the community as she does. And she's always had such a nice reputation. Christine, what would you like to be talking about this morning? We'll remind folks that that home health is
a Medicare certified agency for issues with nursing, wound care, medication issues, new diagnoses that you don't know how to navigate. A lot of times people get a new diabetes diagnosis and go straight to the insulin and have never had to give themselves a shot before, and it all comes, it didn't even happen at a hospital. It happened at a doctor's appointment. So our nurses can come out and teach you, one, how to eat, two, how to give your insulin and manage those highs and lows that you may have. And then not just teach you, but then monitor you and stay with you for a period of time over the first 60 days just to keep an eye on things and have some oversight so they can report back to your doctor.
I didn't know you were doing things like that.
Yeah, I think the benefit of home health too, is to help you in a recovery period or in an overwhelming time reduce the doctor
normally aren't you restricted pretty much to your apartment if you are in home health? There are things you can do. You can go to church, you can go to meals.
Hairdresser, barbershop, meals. The way I look at it, Green Spring, from the front gate to the backwoods is your home. So that's your front door, this is your backyard. So
anything here
within reason. So if you're in home health and you're starting to go to bridge like 3 times a week, and then you come home and you're not tired, you're ready to rock and go to dinner, then it might be time to discharge from home health.
Or maybe if you're in the dance classes.
But if going to, we have had in the past a client who had a social group that she met with after dinner every evening. And she would stop by, but then she was exhausted after she did it. So she went straight to bed. She needed to rest. She slept in the morning. That's okay.
Yes.
And it is nuanced. So we have a lot of people that say, well, you said mom had to be homebound, or I read that home health says that you have to be homebound. let us help you determine what homebound actually is, because it looks different in reality than it does on paper, especially in a community like this.
So when in doubt, you can simply discuss it with your clients. Okay.
Absolutely.
And I think that's an important point. Now, you also do physical and occupational therapy,
as well as speech
in
therapy.
addition, and speech. Is there now a speech pathologist?
We do. We have a part-time flex speech pathologist named Tiger Ecke. She's been with us for a while. And she not only does things with like swallowing issues, but speech therapy also can work on cognition and memory, which a lot of people don't realize that she can do that. And so she does both. She works with us mainly, and then there is a speech therapist in Garden Ridge named Candace who occasionally will support Ty if there's too many visits to do. So we have two people that do work in home health to help with that.
All right, and speech pathology, occupational therapy, and nursing, as you're pointing out. Anything else?
Physical therapy and home health aides, which are a little bit different from home support aides.
Home health aides. Oh, explain that difference.
So although the pool of aides is the same, we have specific aides that are in home support who are trained to do home health aide visits. Home support, you privately pay for. The aide does what's on your little care plan that you create with your staff, your nurse. Home health aides are very limited in scope. They perform activities of daily living with you or for you until you can perform them yourself. So they will help you shower, dress, toilet, get in your scooter or electric wheelchair for the day, maybe even prepare like a light meal or snack for you during their visit. Their visit's usually no more than an hour just to help you get up and going, and usually only a few times a week.
Now, Christina, is that Medicare reimbursable?
It is paid for by Medicare under the home health episode that you're under.
It is. Is that new?
No, it's always been there. A lot of times the clients that we get in home health already have home support on board, so there's no need for it. But somebody that comes to us that doesn't have any in-home support and is struggling to maybe get a full shower, they're just bird bathing at the sink.
Bird bathing?
That's really what it is. You're just kind of splashing and, you know, having the occupational therapist come out and assess your ability to bathe yourself or dress yourself, and then creating a plan for an aide to assist you for a couple of times a week, but also the occupational therapist to teach you how to do those things with your new limitations or your temporary limitations. So we really like to see the occupational therapist in there educating and teaching either you or a caregiver, and then our home health aide can come in and provide support on other days to help you get that bath or shower. Not meant to last forever, but if you are on home health, and you have a functional decline that leads you to needing that assistance, it is there for you.
I did not know that. I think most of us are unaware that there was any aid help.
Yeah, we have
home health.
We have one that's been with us for a very long time named Siggy. I think everybody knows Siggy around the campus. And she is working in home support, but she sees home health clients. And her schedule now has shifted to the evenings. We have some people that actually like that in home health and will let her come see them in the evenings because they love her. And then we've cross-trained 3 more aides from home support who are CNAs into the home health model of providing a care visit. So we have Sandra Ajare, Helen Coloco, and Desireen Burris. And they've all been with us quite a while, and clients really seem to like them. So,
is there a limit to the number of 8 hours in home health?
It's really 2 to 3 times a week. It's meant to be sporadic.
2 to 3 hours a week?
Yeah, and it's a 1 hour or less visit. So, I mean, if your visit takes a little longer, our aide's going to stay until the job is done, of course. But what they're allowed to do during that visit is really where the limit is. So, my expectation is if they give you a bath and, you know, they clean up after themselves, so the towels or maybe the sheets that you needed changed go in the wash, but they don't stay to finish. They just put them in there and get them started. They might make you a quick snack and help get you settled, and then they go about to their next visit.
All right, I see. So their tasks are limited.
They are, and actually they're directed by whoever arranges their care plan. So the nurse or the therapist, occupational therapist, creates a plan for them. They must follow that plan. So if you work with someone and you work up a care plan that says that they're supposed to have a shower, and there's no other options in there, and you give them a sink bath, because that's all they can do that day. They have to coordinate with the nurse or the therapist. There's a lot of oversight for those aides.
Okay.
Because that care plan is very, very specific.
Okay.
So there's a lot of communication that goes into that because, again, Medicare is so heavily regulated by the government.
All right, so that's quite different from home support.
Absolutely.
Where the client is going to designate what needs to be done.
Absolutely. The care plan is really dictated on a client level in collaboration with the home support nurse at the beginning. And then, yeah, absolutely, they ask for assistance with something new or, you know, there's a lot more flexibility also because it's private
And of course,
pay.
that then is private pay, which makes it different. Okay. Well, I was not aware of that. That's really quite interesting. Have the regulations changed much are you seeing from year to year?
They change constantly. We're gearing up for a new change in 2020 that doesn't really affect our clients, but really affects our office staff. And I've spent a lot of time training and actually have another meeting after this to go to the medical center and train the doctors. But the biggest change we're looking at now is the way we're paid for our services in home health. We used to have what we call a 60-day episode. So we would come out and we would look at your situation, we would plot out visits and make a plan for you for 60 days if that's what we felt you needed. And our staff would execute that plan, and at the beginning of 60 days, we would do what we call a wrap, a kind of a prospective payment. Like, this is what we think we're gonna need to do the care, and Medicare would give us 60% of that money. And then at the end of your episode, when everything's complete and tied with a bow, we would send it to Medicare and they would give us the other 40%. And that's a 60-day time period. Now your care is still 60 days. My clinicians' jobs don't change. They're still plotting all this out. But within that 60 days, we now have to bill twice. So we have to open your case and bill for 60. At 30 days, kind of close it out and final bill for 40. And then at day 31, open it up again, and then close it at day 60 again. So
more paperwork.
Exactly. It's a lot more paperwork for our office coordinator and our clinical manager and myself, just making sure that we get all those bills in on time. And it shortens some of the timelines. So I think the one change that our residents will see, maybe, is if you have a home health referral, but you have not been to a doctor, like you pick up the phone and call your doctor and say, hey, you know, I've got this really bad back pain, I'd like physical therapy, and oh, by the way, I haven't been out of my apartment in 3 weeks. They're gonna call me and send me a home health referral, but you haven't seen your doctor in 6 months. I can't really see you until you see your doctor.
Okay.
So it used to be we could see you and you had 30 days to get to the doctor. That doesn't work the same way now. So we're asking people now, you need to get to your doctor within that first week. We'll still come out and open you, but you have to go see your doctor within that first week.
And of course, for people who are homebound, that may be a serious issue.
Yeah, Medicare will not allow us to see somebody without a physician's visit within the 90 days before we start or the 30 days after we start.
Now, can the medical center physicians actually visit people in their homes?
That I don't know.
I mean, what do you do with people who are bedbound?
If they're bedbound, usually they need a higher level of care than home health would technically provide. So that's usually when we get Sue, Elena, or Stephanie involved to kind of problem solve. There are a handful of doctors, not necessarily, I can't speak to our doctors here, but I have seen some notes from physicians who did make a home visit. But they're external doctors and they might be with somebody for the last 40 years, I don't know. So.
I don't know whether our doctors ever do.
I don't know.
Now, of course, people in hospice. Now, let's talk about people in hospice.
Sure.
Do they use your services?
They can use our home support services. They cannot use home health because hospice is a Medicare certified agency, and so is home health, and you can't have two at the same time. Medicare will only pay for one. And generally, hospice does a lot of what the home health nurses do. They can use home support services. They can use the aides. There are a few limitations, and usually people find those towards the end of, like, really close to the end of life when pain becomes more frequent and they need pain medication, but they can't self-administer it. And that's where people get into trouble. I've worked in hospice before as well, and you know, you have someone who has maybe a syringe full of morphine that they need to administer in their mouth when they have pain, but their hands are weak and they shake or they can't lift their arms. Our aides are not allowed to administer that really they can't, the best they might be able to do is provide you with the pre-filled box of syringes and say, here, you need to take your medicine. But they can't even help you push the plunger down. There's rules against things like that in home support. So
particularly opioids, or is that all medication?
really, they can do medication reminders. So if you have some scheduled medications in a pre-filled box that our nurse or CVS did, and if there's opioids in there, they can just say, hey, it's time for your medication.
But they actually can't handle the, again, is that just opioids or all medication?
That really, it's all medication. They cannot physically administer the medications to you. So, people go on hospice, and I saw this all the time. They go on hospice independently with no family nearby and hire a private duty agency, no matter who it is. And then they get to that end of life piece, and nobody really talked to them about what's going to happen when you can't self-administer your own medicine.
Yes.
And so that was always one of my biggest pet peeves in hospice was, okay, you're alone now. Who's going to be with you at the end? I'm going to hire an aide. Well,
right.
That's not going to cover it.
No, it's not going to solve it.
So, yeah.
So how does that work? What do you do?
So here, I don't know what people do because they're using an outside hospice agency, but what I usually did was just try to pull somebody in, a family, if there was a case manager. A lot of times hospice agencies have social workers and pastoral support, and a lot of times we would pull them in to see if there was anything that they could do. Is there someone from church? Is there a neighbor? And they would try to pull someone in to kind of assist. Sometimes with what I did in hospice, we would put people on like a patch for pain that lasted several days, and I would just come out and reapply the patch as the nurse every couple of days. But that doesn't help when someone's having that, what we call the breakthrough pain, that the patch doesn't cover. You still need something. So, you try to respect their wishes to be at home when the end comes, but you also have to be realistic that if there isn't support, what is the backup plan? Is there a place you can go? Is there someone you can stay with? Are you willing to go to an inpatient setting? Because we don't want someone to hurt. And I think for not just our aides, but any aide, that's the toughest piece because you want to help so badly. You love this person you're taking care of, but there are so many rules that are meant to protect them and you. So I think it really starts with the hospice agency having that blunt conversation with them that you could get into this situation. And then, being willing to accept and understand and have the hospice conversations early. I think having a background in both home health and hospice, the one thing I can say is that people are resistant to the hospice conversation at a time where they really do need to be a little more open because they can hear it. When you're in pain or you've had an advancing diagnosis, you're so focused on what's going to happen to me that the hospice conversation gets lost on you.
I'm sure.
And so I really, really encourage people to be open to that and learn as much as you can about it because hospice is not what it used to be. It's a very different thing now. And we have a lot of people that come to home health that frankly are hospice appropriate, but just mentally are not ready to hear it.
Or don't know enough about it to know that they would be eligible and that they would benefit from it.
And it's not the end it's not the end of your life. It's just the beginning of this part of your life. I think a lot of people hear those words and say, well, that's it. That's all there is for me. I'm going to be stuck in my house. Hospice actually is wonderful because you don't have to be homebound to be on hospice.
No.
If you meet criteria to be on it, you can go to, a party, you can travel. I mean, I had people that would say, I need to put my services on hold for a week. My granddaughter's getting married and I'm going to be there. And they would get on an airplane with their family, fly to the wedding, come back and resume their services. So, and they actually provide a lot more, in my opinion, nursing care than home health does, depending on the diagnosis. You really get a little more oversight.
I was going to say a little more personal kinds of...
And more aid care, too. That's the other thing. There's really not so much of a limit on home health aides, home hospice aides when you're in hospice.
Of what they can do and
they can do a little bit more. They can come more frequently. Their visit times are not as limited. I actually had a situation where I sent an aide out twice a day to somebody who really needed help getting up in the morning, and then when their daughter had to leave suddenly for a family emergency, just couldn't get back to bed by herself at night. So we sent an aide at night at 7 p.m. Somebody was wonderful and willing to go for a little tuck-in, but that was her job as a hospice aide, was to be flexible like that.
Is that right?
And I think, in home health, we get these people who are not ready, obviously, but we look at it clinically and think, gosh, hospice would be such a good benefit for them.
Yes.
But they're not there yet. And I really encourage people to just learn what you can before you need it, because I think when you need it, it's just such a hard decision to make at that time.
Yes, it would be. Let me ask you this. If one needed, for example, more medications than hospice was able to come out and provide, could somebody hire home health from you on a private duty, on a private pay basis?
Unfortunately, no, they can't.
You're not allowed to do private pay?
Our home health, not in that way, no,
Okay.
unfortunately. First of all, our staffing and scheduling doesn't allow it, but secondly, yeah, the private pay piece of home health really is, we still have to meet the medical necessity of, what we're doing. And so home health nurses don't administer medications on a schedule. We teach people to administer their own medications. We will come out and give you an injection the first couple of times to show you what to do, but then you're expected to be able to take it over.
Okay.
So, yeah.
Now, so
they can hire
everybody in home health then is Medicare or private insurance reimbursed?
On the flip side, home support, you can hire a home support nurse to do that. If you have
a home support nurse.
Nurse can do it. If you have the money and the communication is there with your hospice agency and they've done everything they can to provide you services, but you still, the only problem is it needs to be on a scheduled basis. Our home support nurses run a schedule. So if you have pain in the middle of the night, you can't call. I mean, you could call, but no one's going to be able to get to you in that kind of time frame that you would need. So it really, when someone is facing end of life care, the planning for that is really, really important.
Okay.
And I keep saying this, but I think that planning that far in advance is really important. I'm 40 years old this year, and I actually have a plan. Because I have 2 young kids, and who's going to take care of me? Where am I going to go? Because my kids can't do that if something were to happen to me tomorrow. Right. So I think we all plan for our retirement and our golden years and what we're going to do and where we're going to live. But I think that piece is missing a lot. And I've even encouraged my friends at our age to go ahead and do it now. Plan while you can.
Well, I think this whole idea of using hospice, both for palliative care, and counseling, as you're saying, is also provided in the service. It's not something that, we used for our parents or anything of that sort. I think it's a generational thing, and that once we've seen it with our friends here or family members, I think it's marvelous.
And I think the palliative model that's really come online in the last few years, because palliative care has always been there, but it's really been like a hospital-based service, but it's really merged out into the community, I think is a really nice way to bridge the gap between no services and full-on hospice. You get that pain management and that oversight without feeling like
And Christine, I think all of us are used to the physician approach, which was you might become addicted. And I mean, as though in the last 2 weeks of your life that mattered.
It's true.
But they were very reluctant often to give pain medication, sufficient pain medication.
Absolutely. And people were afraid to advocate for themselves because they didn't want to be seen that way.
Exactly. Or they were unable to advocate for themselves.
And it still exists now. I mean, I'll just very quick personal, but I'm married and my husband went through a very complicated medical situation and he's out of the hospital now, but was in the hospital for 6 months straight.
Oh my heavens.
And he didn't need pain medicine for the first 4 of those months, but then he had a lung transplant in October. And he's 41 years old, and that hurts. Someone's scooping your lungs out and replacing them.
Oh.
And I was like, you have to be willing to get your pain under control so you can progress and move forward.
Right.
And I'll take just a little bit. And he was afraid to ask for more pain medicine when it wasn't effective because he kept saying, I don't want them to think I'm an addict. I was like, nobody thinks you're an addict. They think you're in pain. Your vital signs show that you're in pain. Your blood pressure is high because you're
stressed.
You're like that, But even someone at 41 years old still has that message from his parents' generation of they're going to think that you're going to get addicted.
Right.
Now we're home and he takes Tylenol if he hurts. He's back to the old, method. But it took me, I'm going to say, a good 7 to 10 days to convince him it's okay. Right? It's okay to take pain medicine. It doesn't make you an addict. You need this to recover. To fully recover and do your best, you need to not have this.
And of course, we're all terrified in this day and age of becoming opioid addicted.
Absolutely, absolutely. And you really have to have those conversations. And then also too, what is the least aggressive pain management you can use? There's so many options now. It's unbelievable what's out there. So he settled on something that really was more of a non-narcotic pain medicine, because
that worked for him.
He did, and he could take it every 4 hours, which is his problem. Was it wasn't lasting long enough. The pain, it brought the pain down, but it came back so quickly. So he needed something he could take a little more frequently. But the one-size-fits-all, model of pain management is kind of gone now. Palliative care is so great. They have so many things at their disposal, and they really do look at the individual and say, okay, what is it? Is it not enough? Is it not lasting long enough?
Yes.
Can they not self-administer it? And they find all different ways to work around those problems. So I think palliative care is, even at home, is just a wonderful thing.
Oh, it is conceptually. Absolutely. And I think we should go ahead and add that hospice, of course, has it, but that otherwise, my understanding is that it's not provided at Garden Ridge.
Now that I don't know. I don't know about
we don't have any palliative care physicians here.
Okay.
So I think, within, there certainly are going to be some pain medications.
Sure, absolutely.
But not as a specialty, which hospice can provide.
Absolutely.
So it really is a terrific service. Are you seeing primarily, is it Capital Hospice that is primarily used?
Capital Caring and VITAS.
What's the other one?
VITAS, V-I-T-A-S.
VITAS, Vitas.
And they're both wonderful. They're both wonderful. I know Capital Caring really has the kind of corner on the market in this area.
They do, yeah.
But yeah, VITAS is another agency. They're smaller, and they're community-based. They don't have a hospice house, so to speak. But the thing that people don't know about places like VITAS is they usually have locations in the community, either a long-term care nursing home or sometimes even hospital contracts where they can do inpatient hospice, just not in their own center. So the company that I used to work for when I lived in Georgia had that. We didn't have our own, nobody had a hospice house down there, but we had specific places we worked with that we selected and formed a partnership with at the time. And
I'd never heard of a hospice house.
Yeah, they have places where you can go at the end if, like I said, if you have that issue with pain medication administration.
My gosh, I didn't. Where is the one here?
That I don't know anymore. I know they used to have one, so I can't remember where it is. Is it?
In Aldi?
Yeah, that's out towards South Riding, I believe. But yeah, they can help with some of those more end-of-life issues, but the criteria for going there is very specific. So just like the criteria for getting on hospice is, the criteria for staying in a hospice house, it's not like you go on hospice and then you're in the hospice house for the rest of your life. It depends on where you're at. Are you having a severe issue that requires that level of care? Is it the end of life and it can't be managed at home for whatever reason? So there's certain things that make you appropriate for the hospice house.
All right. No, I had not heard that. That's interesting. I think we should also indicate, people probably know this, that I think the expectation is 6 months of life to qualify for hospice.
It's actually a misnomer. So
is it?
I've had a lot of people in my time say, well, you told me I had 6 months left to live. I said, no, I didn't. What it says, the hospice certification that we have to provide as hospice staff when I was one, says that if your disease process followed a normal course, statistically, it would be 6 months.
Yes.
But everyone knows about the bell curve, so we're talking about those people right here. And so I actually, unfortunately, just found out that one of my hospice patients passed away in April, and I had him in 2016, and he was on hospice the whole time. So, I mean, that's
Well, sometimes
3
people
years.
graduate from
And some
hospice.
people do graduate out. He remained appropriate for hospice the entire time. He was never removed from it, but he had a disease progression that just was, appropriate from the beginning, but so gradual. And he constantly met criteria every time with just little decreases, and was able to benefit from that for 3 years before passing, and stayed in his home the whole time. So, you've got the people that I admitted somebody who passed away 8 hours after I admitted them. It really just depends.
Yes.
So people feel like we're telling them they have 6 months left to live, but that's
Yes.
not. It's
No,
not true.
no.
You have whatever time you have.
Right. Okay. My goodness, we have managed to fill up this half hour. Christine, many thanks for your comments today. I think this has been a most helpful conversation.
My pleasure.
I've learned things that I suspect our viewers will too.
Great.
So, thanks much.